I'd like to talk about causes of some of these non-gynecologic findings, and I'll talk about gastrointestinal findings, genitourinary findings, that mainly refers to the urinary tract, vascular etiologies, some unusual retroperitoneal tumors, and abdominal wall masses. Now, we all know that ultrasound is an excellent modality for evaluating the female pelvis. But what we're actually doing is we're focusing on pelvic organs. So it's more of a focused examination. When you look at CT has a broader scope of the structures that we can look at. It is used for more generalized type of evaluations. It's much better for evaluation of bowel. We see the entire urinary tract, especially the ureters, which we can't see really with ultrasound. We can see pelvic sidewall structures, muscles, bones, vessels, nodes, etc. And when we deal with complicated pelvic situations, often both examinations are complementary. Now, there are gastrointestinal causes of pelvic pain. Acute appendicitis is probably the best known cause of right lower quadrant pain. We can also pick up colitis, diverticulitis, ileitis, enteritis. Sometimes colon cancers show up on ultrasound. We can see small bowel obstruction and some unusual processes. Most of the time, these are CT diagnoses, but we sometimes see them on ultrasound. Acute appendicitis, let's start with that. This is the most common cause for right lower quadrant pain. We have pain, fever, elevated white count, nausea, tenderness. When the presentations are not typical, when they're atypical, this could lead to a delay in diagnosis, and this is a fear of a lot of clinicians. They do not want to see a perforation or an abscess. They know that this prolongs the course, increases the complications, so they want an early diagnosis. We also want to have a good diagnosis and not to do unnecessary surgeries. And cross-sectional imaging has improved our diagnostic accuracy. We're always trying to balance the perforation rate at surgery and the negative laparotomy rate. In the past, without these cross-sectional imaging techniques, the negative laparotomy rate was running at 20%. We would like to bring the negative laparotomy rate down below 5%, and we certainly are heading in that direction. Now, when we think about which modality to use, we turn to the literature, and the literature shows us that a number of different articles have been written on this problem, and the sensitivities and specificities that are reported for both ultrasound and CT, they run somewhat similar. They're about 76 to 98%, depending on what you read, both for ultrasound and for CT. Ultrasound is limited by a number of factors. We all know about bone and gas, etc., but it's probably best decided by the body habitus of the patient. So if it's a thin, young patient, it should do quite well. In an obese, heavier patient, it does not do very well at all. Those should go to CT. Also, the choice between these two is heavily influenced by the institutional preference and the available expertise. So if your institution does not have people well experienced with ultrasound, they may feel uncomfortable. They'll send all these cases to CT. However, if you have a strong ultrasound section, they may offer to do the ultrasounds first. So that's often institutional preference. Sonography is preferred in children because of the radiation, in thin women because it's easier to get at the appendix, and pregnant women. This is where we should start. We should start with ultrasound. CT, on the other hand, is preferred in heavy or obese patients. Typically, it's preferred in males. Now, even thin males do better with CT because the abdominal wall musculature tends to attenuate the sound, and then we don't have as good penetration. CT is better when the abdomen is rigid, non-compressible. We can't do our graded compressions with the ultrasound, so CT is better there. If we think the process has gone on to more advanced, complicated appendicitis where there's been a perforation or an abscess, we go on to CT. Or if the appendix is suspected or known to be in an unusual location. So here are some CTs showing us appendicitis. Now here is a blind-ending tubular structure that has some fat stranding around it. Look how close it is to the skin. This is easily done by ultrasound. Here's another patient with a very large appendicolith and dilated appendix. Again, this is something that could be visualized with ultrasound because it's right under the abdominal wall. Here's another appendicitis with edema surrounding the appendix and a little appendicolith. If we compress this abdomen, possibly we could see this. And here's a younger patient with an acute appendicitis and a lot of surrounding fat stranding. Again, compression leads us right into the appendix. So all of these cases could be handled fairly easily with ultrasound first. But if we have cases such as an appendix that wants to cross the midline or at least land in the midline, look how deep it is to bowel loops, we would not be able to visualize this with ultrasound because of the interference with bowel gas. Here's another one, shows up in the middle here, protected by all these bowel loops that would shadow out this area. Here's another one that drops down into the pelvis. We could approach this through a vaginal approach if we scan carefully. And here's another one that shows up under the liver, way high up. It goes superiorly and behind the hepatic flexure. That again would be probably very difficult to see with ultrasound. Now, when we want to look for the appendix, one of the first things we have to remember is that this is located not that deep in the body. It's right under the abdominal wall. So we need to look under the abdominal wall, which means it's more superficial, which means we have to use high frequency transducers, usually 7 to 13 megahertz. 5 to 9 is about what most people use, 5 to 10. But we also need to do graded compression, so we want a flat surface to the probe. So we're actually looking at this type of anatomy. Here are our layers of the abdominal wall. Peritoneum is right under here, and under it then resides this acutely inflamed appendix. So we don't have to see that far deep into the pelvis. We focus on this more superficial area. We see here blind-ending tubular structure, multi-layered with some debris in the lumen and surrounding hyperechoic fat. So our ultrasound criteria for acute appendicitis are a blind-ending tubular structure, which is non-compressible and has no peristalsis. We can see, especially in this cross-section, a multi-layered appearance. That's gut signature. What we see is we see bright, dark, and then surrounding brightness. And those are our layers of the bowel wall. The mucosa surrounding that is the hypoechoic muscularis mucosa. Then comes the thick bright line, that's the submucosa. Then comes the muscularis propria, and around that the serosa. So this is classical for bowel. Here's another appendix in cross-section, multi-layered, non-compressible, and it should measure over 6 millimeters to be considered abnormal. Occasionally we will see an appendicolith. So here's our blind-ending tubular structure. It has some fluid in the middle, and then we have a small bright reflector, an appendicolith. Here's another one. You look carefully, and there's the appendicolith with the faint acoustical shadow. We also want to look around at the fat to look for brightness of the fat and hyperemia. Hyperemia within the wall, and also hyperemia of the fat surrounding the appendix. This is not always helpful. to see hyperemia within the wall. It is much more likely to see hyperemia within the surrounding fat. Now, when this appendix goes on to a more complicated state, when it perforates, we have additional findings. We will see interruptions within the wall, disrupted wall continuity. We will see marked thickening of the wall. The appendix gets a lot thicker, over 13 millimeters. They almost all perforate. They can accumulate much more fluid. There are layers of edema around them. There is increased echogenicity of surrounding fat.